Welcome back, and we're going to be talking about several GI cancers here, starting out with HCC and biliary tract cancers. We're happy to have Dr. A.J. Patel from Sarasota, from the Florida Cancer Specialist. How you doing today, AJ?
Doing great, thank you.
All right, so hopefully you can come up with some challenging questions for our faculty. So just to kind of get warmed up, I want to bring up something that we've been seeing a little bit, quite a bit about the last couple of years, Ghassan, which is the issue of response to treatment, but particularly immunotherapy based on etiology of the HCC. You know, when we first started talking about immunotherapy for HCC, and you think about the etiology, everything from, hepatitis to NASH to alcohol, you would think there would be differences in how people respond. And I don't know, at this point, what do we know about that?
Absolutely, it's different. Thanks for having us, Neil. And by all means, this is very different nowadays. What we thought back, and give credit for Snorri Ghassan, he thought about that at that time when he was at the NCI, but admittedly, the tools were not really there yet. But nowadays, we're definitely seeing, yes, it does matter what the etiology is.
And also, Rich, one of the things that we're seeing, of course, when, Atezo-Bev was first reported, to me, it really changed the field. Finally, we were seeing responses in the disease. And it also, at that point, to me, one of the first things I thought about when I saw that Atezo-Bev's data is how is it going to affect local therapy to the liver. Prior to that time, oncologists would come up to me and say, by the time we get to these patients, the interventional radiologists have kind of destroyed their liver. And it was hoping that maybe, if you think about principles of oncology, it makes more sense to start with systemic therapy. Now we're seeing adjuvant data. We just saw the Emerald data looking earlier. Any thoughts about the trend moving earlier?
Well, I think in general, in oncology drug development, we start with more advanced tumors and then work our way to earlier stage. And certainly now we have positive data with IO, VEGF inhibition in the adjuvant, post-surgical, and now after chemoembolization. But an important point you bring up is understanding that this intermediate group, this group of patients that have liver-confined disease, is a heterogeneous group. And some of them who have big, bulky tumors, infiltrative, might be better served with systemic treatments rather than local regional treatments. And that's an area that needs a little more clear definition because now we have drugs with very high response rates.
And AJ, too, another thing that comes in, actually I was thinking of a great case. We were talking about Dr. Kumar, the king of the chat room. He had this case he presented of a patient who was, heavy drinker, who was continuing to drink. And, theoretically, you'd want a hepatologist involved there in terms of dealing with his liver disease. So one of the things I was wondering about is, AJ, we talk about, interdisciplinary care involving interventional radiologists, hepatologists, and conferences, but what really happens out there in the real world? How do you get input from a hepatologist or an interventional radiologist? Is there an interdisciplinary conference you can go to, or you just call somebody on the phone?
Yeah, sure. So I think at our group at Florida Cancer Specialists, it depends on which area you practice in. But in Sarasota, we're very lucky. We have a very robust multidisciplinary tumor board attended by surgical oncologists as well as interventional radiologists who've had experience at academic centers, before they worked at the hospital with us. We have a couple GI doctors who are hepatologists, and we all work quite closely together to decide with new cases, should we proceed with systemic therapy? Should there be some sort of consideration of sequential therapy? I think the Emerald data is really compelling in terms of sequential therapy. We're going to try to use that more often, I think.
Yeah, I'm really curious how you digested that. One of the things that was so cool about that, Ghassan, when I first looked at it, Durva-Bev, I'm like, Durva-Bev, where'd that come from? Durva-Tremi, yes, Atezo-Bev. But then I thought about it. Durva's an IO. Why not combine it with Bev? That's just a side. But bottom line is, you just kind of place Emerald, Ghassan. We'd seen adjuvant, the Empower study with Atezo-Bev, and now all of a sudden Durva-Bev in these TASTE patients.
No, by all means. Actually, I do second what AJ said, which is definitely already is in practice. And the reason, as we're going to see, there was a doubling in regard to the progression-free survival. Add to this, the BEV is not sadly because of the atezolizumab or what have you. The BEV is a very important anti-angiogenic. And the BEV is kind of, I think about it as like mid-level boss in that kind of immune enhancement that happened at the PD-1, PD-L1 level. And as such, will really trigger that ability for the anti-PD-1, anti-PD-1 to do their job. So there's a very important trigger per se that really caused that enhancement. The key element, though, is we are moving, as also Richard just mentioned, we are moving the systemic therapy into the intermediate stage disease. And that's why we're seeing those three prongs where we can see intermediate stage disease being treated like systemic disease as well. But the question is, and this is a novelty, can we bring the intermediate stage therapy into the advanced stage disease? In other words, are we reading the tumor in the liver totally different from the metastatic disease? And then this is the next step is going to see.
Rich, what about radioligand therapy? I think TACE was what was studied in Emerald. Are we going to be able to sort of bring that over to radiolabel therapy?
I think that will be done, but I don't think it's exactly the same thing, right? I think to Ghassan's point, chemoembolization induces ischemia in the liver, and we know that VEGF is a major mediator of recurrence after TACE, as well as its effect on IO. Radioembolization does not induce as much ischemia. It's not as embolic. But this idea that you're treating a tumor and just the question is there real synergy between TACE and medical treatment, or is it just introducing medical treatment earlier that's prolonging PFS? And I think Emerald is still, to me, a little unsettled. We haven't seen overall survival, which might take a while, at least to see a trend, because a lot of times patients might get local regional treatment, and a progression event might be a 1 centimeter tumor in the liver, which we could very easily ablate, versus keeping them on medical treatment indefinitely.
One other thing I was kind of wondering about, we've had cases, I feel like we had a case even yesterday, of patients who get problems with IOs like on the first cycle, autoimmune problem, whatever, and now you've got TACE going on and maybe an embolic syndrome. Do you see any sort of overlap in toxicity, either diagnostic issues or more problems with this happening at the same time, or not really?
I think TACE syndromes are pretty self-limited, right? And IO tox generally doesn't happen after 1 or 2 doses. Certainly we need to be aware of it. But if a patient in Emerald, in reality, they got IO alone with the TACE in the loading part of the study, and patients whose enzymes just start going up very, very high, that is less likely TACE, I think. There's some nuance.
Incidentally, congratulations on getting Aditya Bardia from the MGH. They stole Aditya from MGH, and you had Sarah Hurwitz stolen from you by Fred Hutch. So it's kind of like the sports thing, trading. We kind of follow the investigators. Anyhow, Aditya is a great doc. All right, so let's talk about HCC. Ghassan, let's go through some data.
Sure, thank you. Well, again, good morning, everybody. And so we're going to talk about HCC. And these are my disclosures. And we'll start with the case. 70-year-old lady, history of hepatitis C, secondary dental procedure that was done 40 years ago. Performance is ECOG 0. 6 centimeter liver mass in 7-8 lesion concerning for HCC. No other signs of disease, Child-Pugh score A. And of course, the first, what do? You have a relatively small disease, no vascular involvement, no metastatic disease anywhere else, great performance test of the liver, straightforward, cut it out. So patient goes for a resection, and pathology is positive for hepatocellular carcinoma intermediate grade, and the normal liver shows signs of cirrhosis. As very important, remember Hep C, which can really linger that long, 10 to 30, 40 years before it evolves into hepatocellular carcinoma, and of course is all about a cirrhotic component, which is already there, even though thankfully she is a Child-Pugh A. The patient recovered well, and she comes to clinic, and she clearly comes very clearly, this is New York, so she said, I'm eager to start chemotherapy, I want to live forever.
Really?
Oh, yeah.
She said those words.
Oh, yeah, this is normal. This is like another day at work, so. So the question is, what shall we do? Adjuvant therapy, I made every argument that maybe not yet, and even though we're going to talk about the data, and ultimately she recurred with the tumor in segment 4 or 5 with close vascular involvement with a lesion 8 centimeter in size.
Was Empower out at that point, the adjuvant trial?
So the adjuvant therapy was kind of like in the evolving, correct, because it's already 2 years almost, or 1 year and a half almost, so that's evolving, correct. Yeah.
But you decided not to give it to her.
Decided not to.
How come?
Because the atezo-bev data, and we're going to show it, I would say still not settled yet. We really need to know more data. At least let's wait for a manuscript. Yeah.
All right, please continue.
Of course. So with this, now talk about this. So this is data we're referring to, the Embrace 050 of adjuvant therapy of atezolizumab plus bevacizumab. Great work, no question about it. Give a lot of credit for Pierce Chow from Singapore, who presented the work at the ACR. And you can see here that at least at 12 months, this is really where we can do into recurrence-free survival. We can see that it was 78% and versus 65% in favor of the atezolizumab plus bevacizumab. We don't have medians yet, understandably, and I wouldn't really take it as a negative. To be fair, we know very well with checkpoint inhibitors, things take time. It's like intelligence work. The T cells, the immune system has to train itself until it knows how to fight those, and that's why we can see those, what we could talk about, long tails of the curve, etc. So along that line, medians might be a little bit delayed, but nonetheless, it's still a good sign per se. The question though, and this is really where my response to Dr. Love is, who are the patients? Because on one hand, we know very well that the disease has two versions, and this is actually quoted from Dr. Inamura, but also to give credit, Dr. Chow spoke about it when he presented, which is we have what we called an early stage recurrence and a late stage recurrence. And this is really related mostly to components that really pertain the tumor to recur early, being the microscopic vascular invasion, the high level of the AFP, the non-abnormal resection, and of course, on long term, you have, of course, other components, among which is how active the hepatitis, any chronicity for any multiplicative disease, or even de novo disease per se. I would say, and we look forward to see this in manuscript so we can understand better who are the patients that were treated per se, so we can either follow the same track or same time dissect it further for future studies that will look into adjuvant therapy for HCC. Along that line, I would like to quote an important thing. In our part of the world, the way we resect HCC is like any other disease. You have a tumor, you kind of big a surrounding, a free margin around it, take it out. Interesting, in Japan, they don't do this. If, for example, there's a tumor in segment 4 of the liver, they take the whole segment. The idea is that it's already infected segment. So this really now at least give you a little bit of a view about how important it is to know who are the patients in those studies, and that's why the data is to be awaited for. With this, talk about another component got to local therapy, and this already Neil and all of us have commented on one way or the other, the local therapy, among which, of course, the chemoembolization here that you can see, or the TACE. Interestingly, the early data on the TACE showed immune survival of 3 years. We even perceive this as being curative, like, you do TACE and that's it, which is not the case. But in reality, at that time, 20 years ago, the tumors that were embolized were average size or diameter of 5 centimeters. Nowadays, we can embolize way bigger tumors because, to give credit to our IR colleagues and surgeons who do that, they really have more expertise, more tools at hand, 8, 10 centimeters per se. This is data that I'm showing here. It compared bland and chemoembolization. This is not why I'm showing it, even though they were totally same. This is an effort that we led at Sloan Kettering with an NCI support grant. But the aim I'm showing it is because the median survival for that chemoembolization was 20 months. That's all what chemoembolization can do. And this is an important concept to have in mind because, as Dr. Finn just brought in, what about if a patient has a quite advanced disease locally? Could we consider treating it as systemic therapy? And this is really what comes to this rather pretty bold study. I would not think that it will happen here, but a retrospective even look into in comparison of patients who were chemoembolized versus got systemic therapy. The example was lenvatinib at that point. It doesn't matter which one it is, but systemic therapy. And these patients have what they call up to 7 criteria. The up to 7 criteria is very straightforward to do. You count how many lesions there is in liver, let's say 4, You count what's the largest size of the largest lesion of the liver, let's say 5 centimeter. 5 plus 4 equal 9, more than 7. As simple as that. Size of the largest lesion and number of lesions in the liver. If the number is beyond 7, systemic therapy, as Richard just said, will probably be more valuable. So that's the study. They looked at patients beyond UP7 criteria, and they definitely can see, as you can see in blue, lenvatinib fare way better than the chemoembolization, with survival of 38 months for the lenvatinib. And remember the 20 months I mentioned a second ago from the study at Memorial? Same thing, 20 months over here, 21 months. So clearly, it's not like we're saying, oh, all patients come to the way of the medical oncologist. No, what we're saying is teamwork. We have to make sure that we talk to our colleagues, interact, engage. I like what AJ said at the beginning. We have tumor board. Sit down at tumor board. Actually, it has been noted, by the way, the doctors who are least to go to the tumor board are the oncologists. We got to be there, because otherwise they don't know what you're doing. So that's really important to be there. So trust me, sometimes you will be surprised. They might offer best supportive care because they have no clue what's available regarding systemic therapy. So with this said, what about combining the two together? Yes, of course. Actually, to give credit, Ricardo Lencioni looked at this 20 years ago, looking into sorafenib. It was the only thing available at that time, a tyrosine kinase inhibitor, plus chemoembolization. We looked at it in gazillion ways, even looking at it for response, looking at it for survival, looking at it for tumor untreated for embolization. Everything was negative. Interestingly, 20 years later, exactly 20 years, like the same day at GI ASCO, 20 years, Ricardo Lencioni is back on the podium, and you just saw him back in January, presenting the EMERALD-1 study that looked into now chemoembolization plus durvalumab plus bevacizumab compared to chemoembolization plus placebo. And as we can see here, it showed a doubling in the progression-free survival in favor of the durvalumab plus durvalumab at the chemoembolization. Yes, there are good arguments why this happened. As actually Richard just said, there's definitely a induction of the immune microenvironment system in the tumors with the use of the checkpoint inhibitor, with the use of the chemoembolization that will make it more prone for the use of the checkpoint inhibitor. And as we said, the anti-angiogenic component of the bevacizumab will be more of an enhancer for the durvalumab anti-PD-L1 therapy per se. So this definitely is being in practice, is happening. And of course, we're looking for more details on it as it evolves. But also, there's another one, EMERALD-3, that we proudly were co-leading across the world with China in regard to now chemoembolization plus the durvalumab, tremelimumab, plus the lenvatinib this time. So to answer Neil's question about what about durvalumab, yes, we're doing durvalumab plus lenvatinib this time compared to chemoembolization. And also looking about durvalumab alone, see that lenvatinib with the anti-FGF, anti-angiogenic component can play a role or not. We'll see if this is going to come out or not. This study is open to all of you. It's available at multiple sites are available next to you in the US.
It's durva, tremi, lenvatinib.
Yeah.
Tolerability?
So far, what we have seen is pretty acceptable. We have many patients on the study and no issues at all regard to tolerability. Yeah. Remember, there's no chemotherapy here. Good. So now let's go to systemic therapy. So now we'll move our mindset all the way to systemic therapy. Give big credit. Richard Finn led that study, the EMBRAVE 150. That was very positive. And it really moved the field in a different direction with, as we can see here, this is the original data, but ultimately we know that the median survival is 19.2 months compared to sorafenib 13.3, positive, and this became a standard of care therapy that pretty much most of us are using, actually the most of us are using whenever we are treating patients with advanced HCC. Interestingly, though, this evolved very quickly to also other options available, among which is the combination of durvalumab plus tremelimumab, as we just mentioned. Actually, this is a single dose, one single dose only of tremelimumab as an anti-CTLA-4, which will induce the activity of the anti-PD-L1 of durvalumab, showed an improved survival, as we can see here, 16.4 months compared to 13.7 sorafenib, in favor, of course, of the durvalumab plus tremelimumab. In addition to that, we look at durvalumab by itself as an anti-PD-L1, and we looked at it in a non-inferiority component of the study versus sorafenib, 16.5 versus 13.7, and this was a positive study. I'm sure all of you already are posing, wait a minute, are you trying to convince us that this is a positive study? You just told us about 19.2 months for atezo-bev, and now you're telling about 16.4 and tell us it's a positive study? Oh, and on top of that, you're telling us that Durva alone versus sorafenib, non-inferior 16.5 or 13.7, but a lower number, 16.4 for the Durva-Trami versus sorafenib is superior. Well, let me explain. So, number one, we'll start with the Durva, and I'll keep that for a sec. We're going to talk more about it in a second. Nonetheless, this is, and I know a statistician can help you better than I would do, but this is a non-inferiority mechanism already in regard to how these stats were done. And as such, it will be inappropriate to compare the two numbers of the Durva-Trami to the Durva alone. Take my word, this was a non-inferiority, and I'll show you how it is non-inferiority when we come a little bit later to what will happen to those patients with time with Durva alone. However, in other words, is there a role or a still contribution of the tremelimumab single dose per se? Yes, there is. And interesting, when it comes to that 16.43 compared 13.7, and how does compare to 19.2? As we all know, by the way, I just parked my car outside. I'm selling it for $100. Anybody would like to take it? Okay, first question, you're laughing because, like, what are you selling us? Because if I'm selling you a piece of junk, tell me, thanks, have a good day. Because it will take you more money to pick it out of the lot instead of like buying it for $100. But if it was a Ferrari, because parking a Ferrari in New York will cost me more than the cost of the Ferrari, taking it for $100 is more money for me. So that's why we need, when we do a study, you need to look at the demographics. Who are the patients? And this, sadly, what we sometimes look at the numbers, oh, 19 better than 16, but who are the patients? So let's look into this a little bit more. Here you go. We have a new study that was reported at ESMO in Paris last year, and it shows actually an improvement of the, 2 years ago, and then it was reported after that in Lancet. It shows camrelizumab plus rivoceranib, again, anti-PD-1 plus anti-VEGF, 22.1 month. Whoa, even better than atezo-bev. What's going on here? Again, who are the patients? So let's dissect that. So I'll take you back to the atezo-bev for a second. This is another study that happened. It's real-world data on the atezolizumab, bevacizumab, AB. That's called AB real study. And mean survival for the atezo-bev was 15.74 months, not 19.2. Was there any mistake in either of the two studies? Was Dr. Finn jacking up the numbers? Absolutely not. What happens is, who are the patients? Because in that study, the AB real that was done by the Imperial College in London, 30% of patients were Hep B, 30% were Hep C, and 40% were non-viral. 30, 30, 40. Now, if we look at the importance of that, this is a paper that many of us quoted many times by Dr. Pfister in Nature back in 2021. It showed that actually Hep B generally will fare better when it comes to the use of checkpoint inhibitors, followed by Hep C, followed by the non-viral. This is exactly what Dr. Love was asked about. Yes, the etiology does matter. But very important message for us here. It does not mean that non-viral will not benefit from therapy. Everybody will benefit from therapy, but maybe to a certain lesser extent when it comes to non-viral compared to Hep C, and of course compared to the Hep B. So now you can imagine where the story is going, because when you go back to the etiology and the Ambrave 150, you'll notice that the study had 50%. So you see it all the way at the bottom, Hep B, Hep C. You'll see 50% had Hep B. And this is what Dr. Pfister just told us. Why is that? Because it seems that there's certain type of exhausted T8, TCD8 cells that will enhance that immune activity, even though, to be fair, specifically said, we're not sure what they are exactly. This is written in Nature that we're not sure who are they, but nonetheless, it seems there's some mechanism that enhances the response in Hep B patients. As such, the more Hep B patients, what's going to happen? Survival, going to go up. Less Hep B is going to go down. So exactly this is what we're seeing over here. When we go to the Himalaya, you'll see that we are 30, 30, 40. 30 Hep B, 30 Hep C, and 40 non-viral. Median survival, you saw it 16.7 months. Great. The test is, when we come to the CARE study, I showed you 22.1 months. Well, guess what? 75% patients have Hep B. So now if you want to Hep B, you want a positive study, repeat the Ambrave 150 in like Hep B patients. If you want to do a lower Hep B, a lower survival, just do it in non-viral. This example is set. So please, I urge you, two messages are over here. It does not matter regard to the choice of therapy. The therapy will apply to everybody, but it's anticipated that patient with Hep B will fare the most, followed by Hep C, followed by non-viral. And please, the 19, 16, 22 month, if you ask me, I think those double combinations, all three of them are equal. They are probably in the range of 16 months if you look at it in a generic way for everybody. So with this said, this is where I want to go back. So now, we mentioned already that it takes a while for priming the T cells to really get active against the cancer. And think about it this way. This is like not sniping like the targeted therapy, like tyrosine kinase inhibitor. This is intelligence. You have to send the T cells. They have to investigate behind the enemy line, come back, and start prepping themselves for action. That's why median does not matter much. Landmark analyses, which to give credit, Richard on his paper, on our paper, we did talk about landmark analyses will matter a lot. As you can see over here, now at the Himalaya, we're even able to talk at 4 years survival. 25% of the patients on the durvalumab, tremelimumab are alive after 4 years on therapy. Now, you remember I spoke to you about the durva. If you think to your right, you'll see the durvalumab. It's kind of like closer to sorafenib. It really shows you that this differentiation between the one dose of tremelimumab enhancing the CD28 to send the message to anti-PD-1 and anti-PD-L1, even with one dose, is critical, and that's why this 25% versus about close to 13 or 14%. So, with this said, of course, we're not done yet. This is 3 days old only. And by the way, this is how you get the news on oncology these days, press releases. So, if anything, we really are eager, can't wait to see the data. To give credit, the investigators have been working very hard on the nivolumab plus ipilimumab. We're all well aware of. It appears to be here that the Checkmate 90W for ipilimumab, nivolumab showed improvement in survival. Both, they say, in the press release, clinically and statistically significant. We have to wait and see. Not sure where it is. It will be inappropriate or unfair to comment on anything because we don't know even the data. So anything I'm going to say is going to be speculation, which is unfair. So we just have to wait and see where this will take us. So, what are the options available for us? In first line, who would have thought so? It was like a barely one box for everything, sorafenib. Now we have the atezolizumab plus bevacizumab, durvalumab plus tremelimumab. We'll see, and maybe hopefully soon, we'll see the pembrolizumab plus rivoceranib, and also ipilimumab, nivolumab, pending the data. Sorafenib, lenvatinib. In second line, we didn't talk about it, but you have regorafenib, cabozantinib, ramucirumab, pembrolizumab, nivolumab, and still nivolumab is in conditional approval in that category space. And of course, in third line, we have cabozantinib as well. So, a lot of choices, and no doubt that who are the big benefactor of all of this? Our patients. At least we can help way better than we used to do in the past. So with this said, I can summarize the following. Some things we didn't talk about, but HCC continue to evolve. Actually, the new word is MASH, not NASH. Hepatologists, they like to change words. So it's actually metabolic-associated steatohepatitis. Same, in other words, related to metabolic disease, morbid obesity and diabetes. So this is really what's driving the picture the most. And this is where we have to really roll our sleeves to really know how to take care of patients with non-viral HCC, because it's going to be the predominant reason for HCC. Adjuvant therapy, I would say not there yet. Local systemic therapy is holding the future of both ends, and we'll have to wait and see what will more data show. Checkpoint inhibitors in combination are the mainstay therapy for HCC nowadays. Response to checkpoint inhibitors, however, is dependent on the tumor immune microenvironment, i.e. the etiology, at least for now. But on purpose, I didn't put etiology here because there are many other variables that probably we're working on at Sloan Kettering, trying to pin down specifically so we can move from the guesswork, this is a % chance, to definitely this therapy because of the following immune microenvironment components. And lastly, however, and it's a very important message for all of us, all those fancy therapies that we're talking about probably are accessible to about at most 20% of the human population. And sadly, not for the patients where the highest incidence of the disease is. And that's why we have to remain that access to that therapy and those therapies remain a global challenge. Thank you very much for listening. I pass it back to the chair.
So thanks, Ghassan. We're going to move on in a second and talk about biliary tract cancers and give AJ a chance to throw some questions at you, but let's just follow up on some of the things you said, Ghassan, and get Rich's point of view First, let me go to AJ. Any questions you have after what you just heard?
Yeah, sure. So, is there any genomic signature that would influence you in your decision to make to treat a person with a doublet IO versus IO?
I want to go to Rich on this, and in general, which I think he's kind of getting into the big question, which is optimal first-line therapy, and it's going to be really interesting to see what this Ipi-Nivo study shows. I don't know, maybe hopefully that'll be presented at ASCO. But just a couple, again, quick questions just to sort of balance out in terms of what Ghassan said. Without getting into a prolonged argument, would you like to just in a second capsulize your view of what Ghassan was saying in terms of etiology in response to IOs? Because he has very strong feelings. You feel the same?
I think that Pfister paper was a very good scientific paper, but when they just showed the forest plot of the hazard ratios, it's misleading. Because I can speak very confidently from IMbrave 150, the objective response rate for Hep B, Hep C, and non-viral is all about the same, 28% plus or minus. And that hazard ratio of 1 for non-viral comes from the fact that you look at the survival for the non-viral is 18 months, very similar to the rest of the group, but the survival in the sorafenib group is 18 months. And that was a 2-to-1 randomization, so 100 patients to 50. And I would argue that hazard ratio of 1 is just a reflection that a small group of patients on sorafenib did very well.
I'm starting to feel like the moderator for the presidential debate because I can see Ghassan's ready to leap, but just hold off, Ghassan. We got to get to biliary
And if
tract.
I am elected.
We got to get to biliary tract here because
We do this all the time, by the way, guys.
Well, yeah, these are the two PIs of the trial, and that's the other thing I wanted to go back to you about, Rich, which is that question that AJ, what do you prefer? And people going back and forth, but until recently, most people were saying Atezo-Bev, and Ghassan was saying, Durva-Tremi, and that's fine. But I'm starting to hear the other group leaning more towards Durva-Tremi since they saw the 4-year survival. And the idea that double immunotherapy maybe is going to lead to, kind of the way they think through in renal, even though they don't exactly have indirect, but they feel like Ipi-Nivo, if they can give it, they want to give it. So A, do you think that could be a reality? And B, regardless of the efficacy of what Ipi-Nivo shows, and assuming they use the same dose and schedule of Ipi-Nivo, do you agree that when you use Durva-Tremi, as was done in Himalaya, the incidence of needing to use corticosteroids is kind of like around 20%, whereas Ipi-Nivo more like 50%?
We'll have to see. That was a second-line study with Ipi-Nivo. Ghassan commented that you got to look at baseline characteristics. IMbrave 150 included patients who had main portal vein invasion, VP4. Those were excluded from Himalaya. And even with that high-risk group of patients, we had a median survival of 19 months versus 16.25, 16 and a half with Himalaya. So personally, looking at objective response rate, OS, PFS benefit, which was not seen in Himalaya, I still think IMbrave is the more active regimen, but not everybody's a candidate for that, and certainly Himalaya is an option.
So to be continued, because probably spend the whole hour on this, but let's get to biliary tract cancers, and I want to give AJ a chance to ask some questions. But first, just to set the stage, just kind of clear it out before we get into some of the more interesting stuff, particularly the metabolic stuff. But in terms of, again, first-line therapy. So, Rich, we saw, again, a study with adding Durva to chemo. People picked up on doing, wasn't the greatest benefit, but it was there. So people, I think, have been doing it. Now I think there's more data that's available, I think, with Pembro. How are you approaching this, and what's the chemo backbone here?
Both of them are GEM-CIS, historically speaking. The results of these two studies for their primary endpoints are very similar. I think I can fairly say that it becomes doctor's choice in choosing which IO to use. We'll talk about some of the nuances, but they're very subtle.
So, AJ, would you like to throw out a few questions for them about biliary tract cancers?
Sure. One question I have is there any role for neoadjuvant therapy for people who have intrahepatic disease only and may ultimately become surgical candidates? Is that something you guys do at your local institutions?
Ghassan?
So I would like to, thanks so much, EJ, for that. And I would like to first, however, clarify the 2 words of neoadjuvant and we're trying to do. Neoadjuvant means I can resect it right now.
Sure.
And then I'm preparing the environment for it. But if you are referring to conversion, i.e. it's not resectable and going to turn it resectable, that technically is like treating systemic therapy. And it will apply the same treatment for sure. Okay. Will I, in other words, if the surgeon say, nah, not resectable, it's conversion therapy, so would I do gem, cis, derf? Of course, why not? Yeah.
Okay.
Anything else, AJ?
Sure. I was looking for some input as to liver-directed therapy at cholangio as well. I don't know if we're going to touch on that.
Rich?
There's not a lot of data.
Yeah, I mean, for patients who have intrahepatic tumors that are not resectable, I think the standard of care is still going to be systemic treatment. And that's assuming the patient is never going to be resectable for some comorbidity. However, I have a lady who I saw on Friday, 86, with diabetes, a little frail, had a 3-centimeter tumor, and you give them systemic treatment, there's no endpoint, right? It's not curative. And I actually had them do an ablation, a microwave ablation, and she's been doing great, off treatment, maintaining quality of life. So I don't think it's as routine for intermediate tumors like in liver cancer, in HCC, but certainly I will say I've done it for patients selectively who aren't good candidates for medical treatment.
I want to let Rich go through the data so we have some time to talk afterwards. But one other question, just back to you, Ghassan. What do you consider, sort of the baseline workup of the patient, particularly in terms of tissue assays? Or liquid?
Of course, yeah. So no doubt that biopsy is key, understandably so. And number 2 is liver functionality is an essential component. So liver function test. And understandably, based on liver function test, if there's any limitation that can be circumvented, like for example, biliary obstruction, then we'll deal with this. On the other hand, if it is something that relates to functionality per se, less likely in biliary, but of course to be observing for as well. But short of that is really pretty straightforward otherwise, yeah.
Rich, again, in terms of workup, NGS?
I think certainly, yes, you need definitely molecular profiling.
What about RNA-based? How important is that in biliary?
I think there's various platforms, but NGS is very adequate as long as it picks up the fusion proteins that are fusion changes that have been described, FGFR2 translocations.
All right, let's go take a look at the data.
Again, thank you for having me. Every time I come to South Florida, I wonder why I'm not living here. So here are my disclosures. Here's a case.
Always welcome.
47-year-old lady presents to her primary care doctor, increasing right upper quadrant pain, generally healthy with some chronic conditions, borderline diabetes, hypertension. Exam, unremarkable, except her liver is palpable. Labs are generally normal, except for these enzyme abnormalities. Bilirubin's up a little bit, and here you see her tumor markers, AFP and CA19-9. 8-centimeter mass in the right lobe extending to the left with small nodules in the lungs. Gets biopsied. It's a well-differentiated cholangiocarcinoma. Foundation Medicine is sent, and she is found to have an FGFR2 translocation. So biliary tumors are the orphan of the orphan. 20 years ago, when Ghassan and me and Andy Zhu were the 3 people in the US looking at liver cancer, we were felt to be taking care of the orphan disease. But biliary tract cancer is even more infrequent, though is increasing in incidence, and overall does have a poor prognosis. The only way to cure this disease is surgical, but most patients aren't going to be found for surgery. And it's a heterogeneous disease, both anatomically and molecularly, right? So in this catch bag of BTC, we have intrahepatic tumors, we have perihilar, or the Claskin tumor, we have extrahepatic ductal tumors, or distal tumors, and also thrown in there is gallbladder. And there's different risk factors associated with each etiology, and genetic alterations that are now druggable occur with different frequencies, with the majority of them being in intrahepatic, the ones that are validated, FGFR2 translocations, IDH alterations, but still, HER2 amplification is something that's evolving and occurs in other subtypes.
Do you see HER2 in intrahepatic? Because I didn't see it listed there.
It's not as common, no, single digit. GemCis has been the standard of care for over a decade, and I want to just give you reference here. Survival was 11.7 months in this pivotal study with GemCis versus Gem alone, and the objective response rate was 26%. So the first advance in the space was TOPAZ-1. This was durvalumab with GemCis versus GemCis alone. In this study, patients got the GemCis for 8 cycles and then stopped. Then they went on to maintenance durvalumab. Primary endpoint was overall survival. The majority of the patients in this study came from Asia, and the majority of patients had intrahepatic cholangiocarcinoma. Here's the primary endpoint of OS. Durva-GemCis, 12.8 months versus placebo, 11.5 months. So this control arm performs similarly to what we saw in the initial GemCis study. Hazard ratio of 0.8 is a 20% decrease in the risk of death. You can see the curves separate rather late into the course. Here you see PFS, statistically significant, 25% decrease in the risk of progression, and a tail to the curve with about a 10% delta in progression at a year. Objective response rates were increased, 18% in the control arm, fairly similar to the historical data, increased to 27%. Interestingly, though, the median duration of response with both these regimens was very similar, 6.2 versus 6.4 months. Something that I think is a little disappointing when we think about IO, right? We think about these durable responses. And I think in both these studies, IO is not behaving like it does in HCC or other sensitive diseases. So Keynote 966 came out after, very similar study, GemCis Pembro versus GemCis placebo. In this study, patients all stopped the platinum at 8 months, or 8 cycles, I keep saying that, at 8 cycles, but investigators could continue the Gem for longer at their discretion. Patients are tolerating things, they're responding maybe, we'll stop the cis, but continue the Gem. This study had more patients that came from outside of Asia, but still, most of the patients had intrahepatic cholangiocarcinoma. Here you see the primary endpoint in this study. 10.9 months versus 12.7 months. Very similar results, hazard ratio 0.83. This curve separated a little earlier, but needless to say, very similar data at benchmarks as well. PFS, while there was a trend, it was not statistically significant, the medians, and with longer follow-up, still some delta at 2 years, maybe not as great as we saw in the other study. But when we look at objective response, interestingly, Pembro GemCis, 29% response rate was very similar to what we saw with Durva, but the placebo arm here did much better than historically expected, objective response rate of 29% as well, so not much difference. However, the duration of response in this study was longer with the addition of IO, and you can see at the 24-month benchmark, 18% of patients are still responding versus 6%. And recently, we presented this updated Kaplan-Meier curve with 30 months median follow-up. The medians clearly have not changed. And at 24 months, 25% of patients are still alive versus 19% in the control arm. Now, the other exciting component to this disease is molecular alterations. And therefore, molecular studies need to be done up front, even though these drugs are not being used up front right now. The approvals are generally based on second-line studies. And one of the most potent alterations is the FGFR2 rearrangements, not point mutations, but rearrangements. Currently, we have 2 drugs approved. There were 3, but one of them fell off the market, futibatinib and pemigatinib. You can see they have similar data, 42% objective response rate with Futi, 37% with Pemi. Median duration of responses are quite similar as well. I give Ghassan credit for his important role with the pemigatinib program. These drugs have on-target effects. This hyperphosphatemia needs to be looked for and tracked. Sometimes patients do need phos binders. This is from FGFR inhibition in the kidney. And then patients certainly have other TKI-type side effects, alopecia, GI toxicity. Also unique to these drugs is retinal toxicity. Often we get a baseline retinal exam and then can follow patients clinically if they have symptoms or intermittently with routine exams. The other impact in targeted therapy also comes from Ghassan's lead in the Clarity trial, looking at ivosidenib, an oral IDH inhibitor. IDH1 mutations are involved with cancer cell metabolism. This actually was a randomized study with crossover, but we saw an improvement, essentially a doubling in PFS, which was the primary endpoint, and an improvement in OS, but again, keep in mind there was crossover. Again, toxicities here you see listed: nausea, GI toxicity, fatigue. This drug, though, is very well tolerated. BRAF V600, the most common mutation seen in melanomas, also occurs in other tumor types. And there was the ROAR study that looked at a generic type of tumors, but was driven by genetic alterations. And we saw in the subset of biliary tract tumors that had BRAF V600 a very high objective response rate, 53%, long duration of response, and this has gotten approval by the FDA for the use of this combination. One of the most common side effects we see is fever, which can generally be managed with antipyretics or holding the drug at times. HER2, old biomarker, came out of UCLA, I'm proud to say, has turned up in other tumor types. You heard earlier in gastric cancer, has been known in this disease, especially gallbladder cancers, for some time. Trastuzumab and pertuzumab have both been looked at in various basket studies with objective response rates of 25 to 30%. There are now several data sets available with combination antibodies, antibody-drug conjugates, antibodies and HER2 TKI, tucatinib, and the new drug on the block, a dual epitope, zanidatamab, which is targeting two different epitopes of HER2. All of them here showing very provocative response rates, all in a similar range, all with duration of responses that are similar. And by and large, the responses generally occur in patients who have 3+ IHC or 2+ if they have gene amplification. And here's the data recently from zanidatamab, looking at a very impressive waterfall plot. You can see those tumors that are 2+ have the asterisk. So the majority of the 3+ are responding. And you can see their etiology here. Most of them in dark blue are gallbladder cancers. So frontline right now is GemCis-IO, based on 2 positive phase 3 studies with very similar results. Molecular profiling is a must for all patients because we have molecular alterations that can help people. And there's early signals of HER2. You know, HER2 agents are listed in NCCN, at least pertuzumab and trastuzumab combination, which makes it available, though none of them have FDA approval, unlike the other alterations. And though we didn't talk about it, but I think because it becomes very generic and less exciting. But, you know, there is data to support chemotherapy after frontline chemotherapy, whether it's FOLFOX or Biliary, do provide modest benefit. Thank you very much.
So I think we have time for one quick question. AJ, you had a question about FGFR, you said?
Yeah, sure. So the toxicity management has been challenging for me with the FGFR drugs. I have found that dose reductions has helped significantly, and yet it seems to be an efficacious drug at very low doses. Wondering if you guys have found that as well. Dr. Abou-Alfa, I know you were
Ghassan?
responsible with the studies.
Sure, thank you. Thanks, AJ. So know that the adverse events can occur. The important message is that we probably were a little bit more fearful than we should have. I think it's really need close monitoring. So please make sure you monitor the patient very closely on a regular basis. With this said, this is not stoichiometric. It's not like more is better, like chemotherapy. So as such, yes, no surprise that at an adjusted dose, you probably will get still the benefit per se. With this said, please don't overtreat the hyperphosphatemia, because guess what? You turn it into hypophosphatemia. So please, it's very important, just monitor the patient rather than the number per se. And number two is in regard to the potential ocular toxicity is reversible. So make sure that you have a baseline retinal exam, but at the same time, if it is to occur where the patient might talk especially about the haze in regard to the peripheral vision, a good ophthalmologist will be able to assess and they will monitor enough that you can really go back to the drug after this recovers from.
All right, well, thank you very much. We're going to move on.